I think we have a lot to discuss, so we'll start. So good evening, everyone, and welcome to the third ANZMIG AFWG webinar. We did have some technical problems, but hopefully they're sorted now. On behalf of my co-chair, Professor Van Hoek Tan, welcome again. And tonight's topic is about all things to do with therapeutic drug monitoring. We have a suite of 5 distinguished speakers, which you can see from your program. And I would like to ask our first speaker, Dr. Webb Harvey, to present his talk. He will also be doing the slides for Professor Debbie Mariott, who will be working remotely to give her talk. So thank you very much, Zach.
Thank you very much for the opportunity. Today I'll be presenting a case presentation entitled Painting by Numbers to demonstrate some of the insights provided by longitudinal antifungal TDM in clinical practice, which I would like to introduce you to Ms. Ellen, a 38-year-old woman who presented with a perianal pain and swelling without any systemic features of infection on a background of a recent C6 radiculopathy secondary to zoster. She had no regular medications, she had no and had a very expensive he was a Fijian national who had migrated to Australia to her initial investigation with a white cell count of 4.4 and a mild lymphopenia at 0.47 and some modestly elevated inflammatory markers.
Sorry, Zach, it's Sharon speaking. For those that are not speaking, if they could go on mute, that would be greatly appreciated. Okay, you're on.
Thank you very much. The initial impression for this case was that of a simple perianal abscess and was managed with routine incision and drainage without any microbiology or histopathology being sent. However, the patient had persistent high-grade fevers post-operatively, which precipitated further investigations with a CT chest abdo-pelvis, which demonstrated a disseminated nodular pneumonia, which was multifocal, as well as with intrathoracic and intra-abdominal lymphadenopathy, as well as long segments of colitis both in the transverse colon and terminal ileum, and multiple hepatic lesions. Subsequent investigations over the coming days confirmed a patient having advanced HIV-1 infection with a fully matured Western blot and quite advanced disease with a CD4 count of 27 and a HIV viral load of 198,000. Investigations for a mycobacterial infection were negative and the patient had a negative CRAG. Subsequent colonoscopic investigations demonstrated diffuse ulcerative disease throughout the colon and terminal ileum, the biopsies of which demonstrated evidence of a yeast-like budding organism which could be found within the bowel. This was also subsequently found within a bone marrow trophine, which was performed in the context of the onset of a mixed hemorrhagic and vasodilatory shock state with a ferritin of 60,000, with once again demonstration of a DPAS and methamine silver staining large yeast-like organism with fungal elements with budding, as well as marked hemophagocytosis. And hence the patient was diagnosed with progressive disseminated histoplasmosis with secondary hemophagocytic lymphohistiocytosis in the context of advanced HIV-1 infection. Accordingly, the patient was managed with an induction of amphotericin and then commenced on voriconazole as standard weight-based dosing. She had a therapeutic dose level at day 5 of 1.8, and notably no dedicated immunosuppressive therapy for HLH was required. The patient was subsequently discharged to the community and was commenced on antiretroviral therapy as an outpatient. Unfortunately, this upward trajectory did not continue in terms of our ongoing outpatient care, with a lack of compliance and engagement with the patient frequently not attending appointments and running out of their antifungal therapies, as well as not being particularly forthcoming with their regular, somewhat lackadaisical approach to their medications. This can be reflected in their longitudinal voriconazole therapeutic drug monitoring and the dosages of which was increased during periods of compliance in light of their relatively borderline levels, initially from 200 to 300 to 400 milligrams BD. This unfortunately culminated in an eventual clinical relapse in the context of a social bereavement within the family and the patient ceasing all of their medications, with a clinical relapse in the form of recurrent abdominal and pulmonary symptoms, as reflected by that substantial elevation in CRP charted in purple. At this approximate 6 months of treatment mark, a serial CT scan was performed to assess our ongoing disease burden, which unfortunately demonstrated some pretty uninspiring progress, with an ongoing multinodular pneumonia, ongoing mediastinal intra-abdominal lymphadenopathy, and ongoing hepatic lesions. In light of this clinical progress, the patient was transitioned from voriconazole to itraconazole, specifically of the super bioavailable formulation in light of their issues with previous levels. Unfortunately, this was not the silver bullet that was hoped for in this clinical determination, as once again, the patient had many issues with being engaged with clinic and frequently ceasing their antifungal therapies. However, during the periods of compliance, there was dose escalation based on levels, initially from 100 to 200 to 300 milligrams BD. Of note, clinical disease was managed to be suppressed even with subtherapeutic levels, which would not be within what would be the recommended targets for most cases of invasive fungal infection being managed with itraconazole. And unfortunately, in another family, familial bereavement, the patient did have a clinical relapse following a prolonged period of cessation of treatment. The itraconazole TDM consensus recommendations is that for a therapeutic level when treating invasive fungal disease between 1 and 4 milligrams per litre. The data for this is mostly derived from management of invasive pulmonary aspergillosis, and well as in prophylaxis data within the hematological stem cell transplant community. Notably, there are high itraconazole ECOFs in Aspergillus fumigatus versus that of Histoplasma capitulatum. And notably, the Histoplasma capitulatum itraconazole MIC90 is substantially lower than that of voriconazole, that of 0.6 versus 0.25. Hence, probably the reason that it recommends for the first-line treatment in terms of azoles for histoplasmosis. This has been somewhat further investigated with the 2021 publication of a small retrospective study, which demonstrated a trend towards mortality benefit in the first 42 days of treatment with itraconazole versus voriconazole. However, the voriconazole arm in this study was particularly small, comprising of only 10% of the patients. And interestingly, there was no TDM data that was included. In light of the lower MIC90 of itraconazole, it's feasible that this potential effect could be accounted by early phase of subtherapeutic voriconazole doses without direct TDM, with easier attainment of therapeutic levels being established with empirical dosing of itraconazole. However, this is all being postulated as this data was not included and would require further investigation. Ultimately, this case demonstrates some of the benefits of longitudinal TDM in allowing us to paint a picture, and hence the somewhat tenuously related title of this presentation, of longitudinal disease control in the case of invasive fungal infection, particularly in cases such as disseminated histoplasmosis, for which the treatment duration is not particularly well defined, being recommended as being generally at least 12 months, which in this instance would be reflective of the fact that we would likely definitely prolong our therapy with the data that's provided by our longitudinal TDM, giving us an understanding of the patient will unlikely having a proper 12 months of treatment. This overall needs to be taken into the greater picture of the patient, including their on-dose CD4 count, etc., and ongoing disease burden, but it demonstrates that the TDM really does allow us to give an understanding of our disease control. Particularly in the context of a patient that is poorly compliant, the fact that they've managed to have effective clinical suppression in the instance that we were going to go for a long-term suppressive strategy as to whether or not we would consider reduction of her ongoing doses, with the 300 milligrams BD presenting a significant pill burden and probably hindering her enduring compliance based on these levels. In summary, this is a case of disseminated histoplasmosis with secondary HLH in the context of advanced HIV-1 infection, whose longitudinal management has been complicated by poor compliance in the context of recurrent social stresses. Regular TDM provides insights into our longitudinal disease control and allows for compliance monitoring in patients that aren't particularly forthcoming with their medication adherence. This case demonstrated suppression of active disease correlating with our detectable antifungal agents, but with interestingly maintained control below the recommended therapeutic targets for itraconazole. And it's of interest as to whether the potential survival benefit of itraconazole versus voriconazole in a small study could be accounted for by subtherapeutic voriconazole levels. And notably, there are not specific clinical-based data for histoplasma therapeutic itraconazole level targets. Thank you very much for your time.
Thank you very much, Zach. So we will not be taking questions after each talk, but there will be a general Q&A after the talks. And therefore, I would now like to invite Professor Debbie Mariott, whom you will all know well. Debbie is a senior staff specialist at St. Vincent's Hospital in Sydney, and she has had a long-standing interest and research capability in therapeutic drug monitoring. So over to you, Debbie.
Sorry about that. Stack's kindly agreed to show the PDF of my slides for me because we've had some technical issues. So my talk tonight is entitled A Garden Variety of Fungus. Thanks, Zach. So the patient is a 59-year-old gentleman who's extremely healthy with no comorbidities and actually undertakes regular gym workouts. So very fit and healthy gentleman. In March 2022, he was visiting his aunt in Adelaide and thought he may have stood on something in the garden, but there was no obvious splinter, no laceration, nothing to actually see, and he forgot about it. 3 months later, he developed increasing discomfort in his left hip and evolving limp. And he was referred to an orthopedic surgeon who undertook an MRI. And you can see in this MRI that there's very active hip joint synovitis with large erosion into the acetabulum associated with extensive reactive bony edema. And there's associated iliopsoas bursitis and edema of the quadratus femoris and adductor muscles around the hip. So extremely extensive involvement of the hip joint and muscles. The orthopedic surgeon undertook a hip aspirate and an arthroscopic synovial biopsy, and there was marked suppurative neutrophilic inflammation of the synovium and cartilage. And on histology, fungal hyphae, reminiscent of Candida, don't you just love histopathologists describing fungi, was seen, but no spores were evident in both necrotic and viable cartilage. Next, thanks, Zach. And surprisingly, Scedosporium apiospermum was grown from the synovial fluid and cartilage biopsies. You can see here that it was very susceptible to voriconazole with an MIC of 0.12, the most active of all the drugs. Next, thanks, Zach. And so he was commenced on voriconazole with a standard loading dose and then 200 milligrams twice daily. And he had trough concentrations measured very regularly, usually every 2 to 3 weeks. And they ranged between 2.3 and 5.5 and were always within the therapeutic range. He had a progressive clinical response and normalization of the inflammatory markers over the next 3 months and became asymptomatic, and therefore his voriconazole was ceased after 3 months by the treating physician. Next, thanks, Zach. However, 2 weeks after the voriconazole was ceased, he represented with a worsening hip limp and markedly increased pain in his left hip, and his C-reactive protein had risen from normal to 38. He had a repeat MRI done, which showed ongoing synovial inflammation, and a repeat arthroscopic washout and biopsies were performed. Once again, the histopathology showed acute synovitis with inflamed fibrinous tissue consistent with infection, and once again, there was a scant growth of Scedosporium apiospermum. So he was recommenced on voriconazole with a loading dose and was planned for a major 2-stage hip replacement under voriconazole cover due to ongoing deterioration and irreversible hip damage. So the plan was for a hip arthrotomy and debridement of the joint, followed by an insertion of a cement spacer impregnated with voriconazole, and then a total hip replacement 6 weeks later. At this stage, the patient asked to be referred for a second opinion. Next, thanks, Zach. So why the treatment failure when the MIC seemed very reasonable? So, as I said, for successful therapy was a low MIC, 0.12, and we know through regular monitoring that he had therapeutic voriconazole concentrations. So why did the treatment fail? Perhaps there was inadequate tissue penetration at the site. So if you look at voriconazole tissue penetration into various sites, you can see it penetrates well, for example, into the brain at 1 to 2.3 times serum concentrations, but relatively fairly poorly into the synovium at only 0.25 of serum concentrations. So perhaps the tissue penetration was inadequate, but perhaps other factors were also in play. Next, thanks, Zach. So I think there's something else that also was in play is a biofilm. And the biofilm is beautifully described in this paper as a typical social cooperation system. Biofilms were first described by Van Leeuwenhoek, sorry, Jan-Willem, you can correct my pronunciation, who reported on the concept of microbial aggregation first on the surface of teeth. Subsequently, Louis Pasteur described the microbial community to be the cause of wine becoming acetic or vinegar-like. And subsequently, biofilms have been defined as communities of microorganisms organised and embedded in a self-produced extracellular matrix, also called the extracellular polymeric substance. And this is composed of glycoproteins, glycolipids, mono and polysaccharides, extracellular DNA, minerals, and water, which work as an adhesive favouring cell-cell and cell-substrate interaction network. And additionally, host factors can be incorporated into the biofilm, such as serum and salivary glycoproteins. So, does Scedosporium form a biofilm? It does. So, scedosporiosis, as we know, is initiated either by inhalation or traumatic inoculation of conidial cells, which then go on to germinate into hyphae that subsequently promote host cell and tissue invasion. We know that the mycelial biomass formed by Scedosporium and Lamentaspora species can form a typical biofilm structure with a robust mass of hyphae surrounded by an extracellular polymeric matrix. And here you can see electron microscopic examples of conidia, germinated conidia, and hyphae forming a biofilm under electron microscopy. And this is, in both cases, is Scedosporium species. You can see it's an incredibly dense network forming, as they say, a biofilm community. So biofilms are important because in vitro studies have shown that for Lamentaspora and Scedosporium, organisms in biofilms are 2 to 1,024 times more resistant to azoles, echinocandins, and polyenes than observed in the standard planktonic conidial cells, with which we do susceptibility testing. And the increase in the resistance profile is mainly due to the presence of the extracellular matrix forming a protective layer, efflux pumps within the biofilm, and a highly adapted response to oxidative stress. Next, thanks, Zach. So, for example, if we look at this paper that looks at Scedosporium apiospermum, you can see that in the planktonic form, the non-biofilm form, for conventional and liposomal amphotericin, the MIC rises about 8 to 32-fold between the planktonic and biofilm form. However, for voriconazole for Scedosporium apiospermum, the planktonic biofilm of 0.125, which is very similar to that seen in our patient, rises to between 32 and 128 within the biofilm. You can also see that the environment has an impact on cell dispersion. So once the biofilm is mature and disperses cells out to keep the biofilm underway, then an abundance of nutrients and mucin increase cell dispersion, nutrient restriction and biofilm maturation reduce cell dispersion, but voriconazole and glucose concentration have no impact whatsoever against cell dispersion. So it does not stop cell dispersion taking place from the biofilm. So both the MIC are increased and cell dispersion is not impacted in the presence of azoles. Next, thanks, Zach. So what happened to our patient? So our patient was commenced on alorifim under a compassionate access program that we were able to get access to, had a standard loading and subsequent maintenance dose, and had very rapid improvement in pain and normalisation of his inflammatory markers. And having been unable to climb more than a few stairs, he was rapidly able to climb 12 flights of stairs and undertake regular gym sessions in less than a month. And most importantly, subsequent imaging has shown that there is now no requirement for surgery. And interestingly, alorifilm has recently been demonstrated to actually have biofilm activity, unlike the azole antifungal drugs. Next, thanks, Zach. So I think the lessons from this case are that the organism may be susceptible in the microbiology laboratory, and regular therapeutic drug monitoring confirms therapeutic concentrations of a drug, but treatment can still fail despite apparently optimal management. And other factors such as tissue penetration to the site and biofilms can play a critical role in response to therapy and should be considered in cases of therapeutic failure in multiple clinical settings, particularly those where a biofilm may be an issue, such as lung tissue, hip tissue, and so forth. And finally, where did the title come from? Well, the surgeon who saw him for me as a second opinion wrote, "This poor gentleman is infected with a garden variety of fungus." To this day, I don't know whether he was being ironical or he truly believed it was a garden variety of fungus. Thank you, and I'm happy to take any questions during the discussion at the end.
Thank you, Debbie. And it just shows that, you know, we know voriconazole very well as a as a drug. It's a wonderful drug, but it's a very, very difficult medication to use, and I'm sure that you will all have questions for Debbie. So I'd like to hand over to my co-chair, Professor Tan Van Hoek, who will introduce the next speaker. Thanks, Van Hoek.
Thanks, Sharon, and thank you very much, Debbie, for, as usual, a very inspiring lecture. Now it's time to introduce my good friend and colleague from the Asia Fungal Working Group, Dr. Lily Low, who is an infectious disease physician from Alffenaar in the state of Kedah, Malaysia. Lily will speak on the topic, how the microbiology lab can support TDM. Lily, please.
Thank you, Dr. Tan, and thank you for our new speaker for sharing an excellent case just now. So my name is Lily, and it's 4:30, close to 5 from Malaysia. So good afternoon, everyone. So this is my topic today, and we know that a microbiology lab do not always run the TDM service, but we want to know how could the microbiology lab support in terms of the TDM service. Okay. Sorry for that. So now, when you're talking about therapeutic drug monitorings, we are referring to the measurements of the serum drug concentrations or its active metabolites, for example, the itraconazole. So what we are interested here is to see that when the drugs is within the therapeutic range, is associated with the adequate exposure, therefore it will give rise to the very optimal clinical outcome. And we try to avoid subtherapeutic level to prevent the selections of mutations. And of course, in addition to that, we want to prevent drug toxicity. So when you interpret the TDM, usually we have to correlate with the MIC or the fungal susceptibility to the drugs, in addition to the host factor. So the host factor listed in the table on the right side, which I'm not going to elaborate here. So now, so the targets for the antifungal TDM, the study of the antimicrobial PK/PD is always based on the exposure-response relationship of the drugs as well as the infecting pathogens. For the good therapeutic outcome, it is important to select the antifungal agent that is based on the MIC of the organism. And when a pathogen is being isolated by the lab, usually the lab will be able to provide us with the MIC information. Of course, that's not always the case because we know that some of the modes is not easy to perform or determine the MIC in the lab because the process is just too complicated. For an individualized TDM interpretations, MIC is needed to determine the PK/PD target, and a pathogen with the MIC value that is far above the resistant breakpoints, MIC-guided therapy is not feasible because by increasing the dose in this scenario, we won't be able to overcome the resistant mechanism. So now, these are some of the PK/PD indices whereby to monitor or to assess the clinical efficacy, and it's all depending on the PK characteristic of the antifungal agents, be it is a time-dependent or concentrations-dependent drugs. So you can see here the PK/PD index. What is important here is MIC is always served as the denominator. So sorry for that again. So CLSI and UCAS have published the clinical breakpoints for the yeast and also some of the filamentous moles. But unfortunately, there's still a great number of moles in particular, whereby the clinical breakpoints have not been determined. So in this regard, the alternative way is perhaps you could refer to the ECV or the PK/PD breakpoints. And ECV is referring to the epidemiological cutoff value, whereby ECV divides the pathogen into the wild type and the non-wild type. So pathogens with the high MIC that are coming from the non-wild type group, usually they are highly resistant to the given antifungal agent, and therefore we should not be using this antifungal agent to treat this type of organism. So in practice, or rather a common understanding, when clinical breakpoints not available for the isolate or the fungus that been cultured by our lab, The interpretation is usually we refer to the MIC range for the closest species or the related species. And we know that this is not the most ideal method, okay, as antifungal susceptibility patterns varies between species of a given genus. So as far as possible, we should take effort to identify the fungus up to the species level. And some of the example here, C. gravata. We know that C. gravata exhibits low susceptibility to aerosol drugs, unlike weekends or tropicalis. And for Aspergillus fumigators, this is the commonest Aspergillus that isolate from a clinical specimen. Usually it is susceptible to triazole, but it is not always true, because we know that some parts of the world azole-resistant Aspergillus fumigators has been a problem. So, however, there are some non-fumigators Aspergillus, they are intrinsically resistant to amphotericin B and even azole, as illustrated on the table on the left-hand side. So, what are the limitations of MIC values? I'm sure that some of you will be asking the questions. What if we do not have the MIC? Because MIC is not readily available, or not all laboratory will be able to give you the MIC value in a real-time manners. Okay, and on top of that, there are various methods that the lab adopted to determine the antifungal MIC value. So the MIC results may be driven because of the methodological variations. So therefore, it's not easy to compare it. Okay, and what if the culture is negative and there is no MIC? And from clinical set points or as a clinician, we always, not uncommon that we start antifungal therapy as empirical treatment, either based on fever-driven or preemptive treatment. In this regard, the lab will tell you culture is negative. Therefore, you do not expect that the lab will be able to provide you with the MIC. So this is really a difficult scenario, and often that we face this kind of scenario because we won't be able to culture the moles, or sometimes it's only PCR positive, therefore we do not have the culture results. So in this scenario, some suggestion is to refer to the MIC of the highest clinical breakpoints for these suspected pathogens, although this is not the most ideal practice. So, okay, so now, coming to fluconazole, we know that this is a drug with a very wide range of therapeutic range. So meaning that even though using it at a higher dose, you do not anticipate to see toxicities due to the fluconazole. Therefore, TDM is generally not recommended when using fluconazole, except in the specific clinical scenario that is summarized on the right. So when they're dealing with the Candida species that with a very low MIC less than 1, and we know that the standard dose of fluconazole 400 mg per day is probably adequate. But however, if let's say the Candida species is with the MIC of more than 4, or even within the susceptible range, but with a higher MIC rate value, in this regard, I think we should probably calculate or adjust the dose based on the PK/PD target to make sure or to ensure that we have a better clinical outcome. So in contrast, voriconazole is a drug or azole that with a very narrow therapeutic range, and it also has an unpredictable PK profile. So if we're dealing with the pathogen whereby with high MIC value, it's unlikely that by adjusting the dose of voriconazole, we'll be able to achieve the PK/PD target without exceeding the toxicity level. So voriconazole, in contrast to fluconazole, whereby fluconazole for the dosing aspect, there are more rooms for dose adjustment, but this is not the case for voriconazole. So this is one of the quite recent publications. It's a multi-center randomized control trial among the hematological patients with invasive aspergillosis, whereby they were comparing two arms. One arm is the group of patients non-TDM monitored voriconazole therapy. The other arm is TDM monitored voriconazole therapy. And the findings of the study shows that there was no significant difference in terms of treatment outcome or mortality. So the authors commented that one of the challenges that they faced was a difficulty in assessment of treatment response, in particularly radiological response, because we can't compare chest X-ray with CT scans. So the author concluded that for analysis of exposures and response relationship, we need to incorporate TDM into MIC in addition to the patient defense system. So likewise, I have mentioned just now, for the analysis of PK/PD response, we need to have good tools that enable or can help us to monitor the clinical cure objectively. So these are some of the surrogate markers that we can use to evaluate the therapeutic response. For example, time to culture clearance or the reductions of a CFU for the yeast infections as well as the tularomycosis. As for fungal biomarkers, there are quite extensive studies showing that serum galactomannan is a good prognostic markers for the monitoring of the disease progress in case of hematological patients with invasive aspergillosis. There are also a number of studies showing that serial monitoring of BDG or beta glucans, there's a good correlation with clinical outcome in terms of invasive candidiasis, but in this aspect, we need further study to prove the efficacy of correlations. So that's coming to my probably the last slides. Okay, for good cuisine or good food service, we need a whole team that working together from the kitchen in terms of when we're talking about food. As for TDM, okay, so a clinically meaningful TDM, we need the collaborations of multidisciplinary team, okay, and ID physician, microbiologists, and pharmacologists, pharmacists, and etc. And don't get me wrong, this is not ID physicians. We ID physicians are always friendly. We are not as grumpy as the chef here at this dinner. So unless that in a day whereby we miss our morning coffee. Okay, I've already mentioned about this. TDM or antifungals is a multidisciplinary approach. And Remy has a dream against the odds. He wants to become a chef. We also hope that one day MIC and TDM guided patient-specific therapy will be a dream come true. With that, thank you for your attention, and over to you, Dr. Tan.
Thank you very much, Neely, as usual, for a very clinically enlightening lecture. So now it's my pleasure to invite Dr. Sumith Mathew, who is from the Christian Medical College in Vellore. Okay, Dr. Mathew, please.
Thank you, Dan, for introducing me. Here in Christian Medical College, we have started TDM of antifungals 2 or 3 years back. And there are many good experiences we had. There were cases where we couldn't detect any antifungal levels in the blood after a few months of treatment. So it is an interesting field. Antifungal TDM is an interesting field. So I will start my lecture straight away. So my focus here is how the pharmacokinetics affects the exposure of drugs and how you can optimize the drug doses to attain certain target concentrations at the earliest, and how the MIC reports will help optimize the exposure to antifungals. So this is our TDM unit. And in the TDM unit, we have a patient procedure room where we take multiple samples at specific period of time. We ask extensive questions. And when it's not possible for the patient to come to the TDM unit, we have phlebotomists who are trained to do samples even from ICU at specific time. So they go to the wards and collect the samples at specific time. And we have a laboratory in the TDM unit where we do the estimation of drugs concentrations, and we have a team to do the reporting. So commonly the TDM laboratory, the instruments that is normally used are immunoassays, high performance liquid chromatography, LC-MS or LC-MS-MS. So these are the instruments used for the analytical chemistry. And why we perform TDM? So previously, if there is no TDM, this is how it usually works. We administer a drug at a specific dose, and we wait for the therapeutic response to happen. And if we do not see a therapeutic response, we either adjust the dose or may change to a different drug. Now, with TDM, what we can see is the concentration of drug in the body, in the blood, or the accessible concentration. It can be a CSF, it can be a synovial fluid, it can be ascitic fluid. So accessible concentration. Commonly used is plasma or blood. And we see that if the concentration or exposure to drug is less, then we can objectively do the dose adjustment. Or if the levels are high, we can decrease the dose. Now, there are a lot of factors which can affect the plasma concentration of drug. You know the age, sex, body mass, index, the genetic polymorphisms, route of drug administration, bioavailability, plasma protein binding, drug-drug interactions. There are a lot of factors which can affect the plasma concentration of drug. So our hypothesis is the concentration in the systemic circulation which is closer to the clinical efficacy and toxicity rather than the dose of the drug given to the patient. So this is one study which shows that voriconazole, we observe a huge interpatient and intrapatient variability of drug plasma concentrations. And there is no correlation between dose and concentration. This is an interesting case of itraconazole treatment failure we had in our department. So one patient with mycetoma started on itraconazole of 200 milligram BD. Patient underwent treatment for 3 months, and the patient was not getting improved. So it was a recent introduction of test itraconazole and hydroxyitraconazole. Hydroxyitraconazole is the metabolite of itraconazole. Both are active. And we found that the levels were below the level of detection. So we had an active engagement and active discussion in the department. So I immediately said, no, the patient is not taking the medicine. But so to prove the point, I asked the patient to come back on the same day. So after taking the medicine, this is 4 hours post taking the medicine. Normally we take the trough sample, but this is, we call the patient again. And after taking a sample 4 hours after the dose, which measured the concentration of itraconazole and hydroxyitraconazole, and still that was also below the level of detection. And patient was consistently telling that she was taking the medicine. So we looked for the other co-medications, and that time this test was recently introduced, newly introduced test. So it was interesting to note that rifampicin can interact with itraconazole, but to the extent that even you won't see an absorption peak. So we searched for literature and we found that it results in presence of rifampicin can result in substantial decrease in itraconazole azole concentrations in serum. Not just rifampicin, phenytoin, carbamazepine, etc. So these are drugs which are prone for a lot of drug-drug interactions. So what are the things that we look for in a TDM lab? We look at the trough, we look at Cmax, area under the curve, AUC by MIC, T more than MIC, Cmax by MIC, Cmin by MIC, and steady state average. These are the common parameters that we look at to see the drug exposure, and some of them with relation to the MIC of the organism. So MIC, as you all know, this is a concentration of the drug which can inhibit the fungal growth, right? So concentration is in the y-axis and x-axis is time. This is called concentration time profile. And if you give a drug, as you see in the picture, yeah. So when you give the drug concentration increase and then it falls, right? And when you give the drug next dose of the drug, again it increases and it falls. So what is a trough? A trough is a sample collected half an hour before the next scheduled dose. That is called a trough. And Cmax for IV infusions, if you give a drug as IV infusion, Cmax is at the end of the infusion or within 30 minutes after infusion. That is Cmax. And what is AUC? It is the area under the concentration time profile. So this is one concentration time profile. And if you need to see the AUC over a period of 24 hours, that's normal parameter that we look at. Exposure over a period of 24 hours, AUC over a period of 24 hours, not just the interdose interval. If this is a drug administered every 12 hours, then AUC calculated from this point to this point is the AUC for 24 hours. And there is another parameter, Cmin by MIC. What is Cmin by MIC? This is basically the concentration that you see here. This concentration divided by MIC will give you the Cmin by MIC. AUC 24-hour by MIC, as I mentioned before, you need to estimate the AUC over a period of 24 hours and that divided by MIC of the organism, that will give you the report. For example, voriconazole, what we need to aim for a good efficacy is Cmin by MIC of more than 2. And some extra points. This is the interdose interval, the time gap between the two doses, between the two doses. And the time the antifungal concentration is above the MIC, that is called T more than MIC. Okay. Next term is steady state average. So this is usually estimated at steady state concentrations. It takes some time for drug with long half-life to reach steady state. And once it reaches steady state, you can do the steady state average. What is it? It's basically the AUC over a period of interdose interval divided by the time of interdose interval. For example, if the AUC is 19, you divide that by the interdose interval time is 8 hours here. So 19 divided by 8, that will give you 2.375. So as I have mentioned before, some drugs can take some time to reach steady state. So it is important for certain antifungal or antibacterials to reach the steady state concentrations fast, because otherwise you're delaying the patient to have adequate drug exposure on time. Especially this is important for treating critically ill patients. In those cases, giving a loading dose will help. So a high dose, loading dose is a high dose given just to ensure that it's reaching steady state faster. So when to perform TDM for antifungals? For itraconazole, if you are giving a loading dose, you can monitor in 5 to 7 days. And if there is no loading dose, you would wait for 10 to 14 days. And for voriconazole, this is a drug which follows nonlinear kinetics. So whether a loading dose is given or not, we generally measure at 5 days. And some papers say you can even measure, if you give a loading dose, you can measure at day 3 onwards. Then for posaconazole, if you give a loading dose 5 days, otherwise 7 days. Isovaconazole 5 to 7 days if a loading dose is given, otherwise if a loading dose is not given, takes 10 to 14 days for steady state to happen, and then you can monitor. But for fluconazole, normally you don't monitor, as Lily mentioned before, you don't measure fluconazole for all the patients. But in certain cases, in critically ill patients, you can measure fluconazole. If you after attaining steady state at 5 to 7 days. Now, how can we achieve these target concentrations fast? So there are programs to help you with that. First is get a proper dosing history. What time the first dose of antifungal was given, what are the maintenance doses, what is the loading dose given if it's given, then the date and time, the body weight, the gender, concentration information, and it need not be a tough concentration. You enter all that information into a software, and here we use the software called BestDose. It's a Bayesian software. And we can plan the treatment. So in this case, you can see that a dose of 1000 milligram was administered as an oral dose, and we are targeting a concentration of 2 milligram per liter at 12 hours after giving the dose. So this is how you plan the treatment. You can either opt for optimized dose regimen or forecast dose regimen. If we aim for optimized dose regimen, then to attain this concentration at this time point, what is the dose to be given? That will be calculated. That is when we click optimized dose regimen. And if we do the forecast of dose regimen, whatever dose that we have entered will be taken, and the predicted concentrations will be forecasted. So this is one example where we have done for voriconazole. You can see at only 2 points we measured voriconazole concentrations. Unfortunately, this was an OP patient, and we couldn't do multiple sampling in this patient. So this was the only option left. So we have measured at 2 points, and we have suggested a dose. So BestDose works with multiple model Bayesian adaptive control, where you can actually see the one particular concentration that we have estimated, what is the observed error in prediction. And each is called support point. So one support point will explain the kinetic parameters for one patient. And so in the non-parametric method, we use multiple support points, and we take the average support points which have maximum probability. So that's called multiple model Bayesian adaptive control. BestDose use that. And basically, it is to determine the kinetic parameter of the patient who has come for treatment. We look at the quality of the model. If the prediction is really good, we will use that estimates to help with dose optimization. So you can also see the AUC at the interdose interval as well as the cumulative AUC, even though only 2 samples are taken in the entire treatment duration. So it will suggest you the doses and the target achieved. So for these doses of 1000 milligram followed by 600 and then 500 milligram, these are the predicted target concentrations that can be achieved with that patient. So what are the advantages of Bayesian approach? You don't have to wait for a steady state, and you can sample at any point in time, and you can obtain AUC with fewer time points. So we have established a workflow in one of our ICUs for active therapeutic monitoring. So we initiate TDM with ICU technical assistant. So they continuously feed us the information of all the patients who are on specific drugs, for example, voriconazole. That information will be received by the person who was working in pharmacology department, TDM consultant. They identify a patient and discuss with a TDM lead, and they contact the ICU registrar. So this ICU registrar will help with the timed blood collection, and the turnaround time is maximum is 72 hours. And we come up with dose optimization discussions after seeing the levels, and we inform that to the ICU consultant, and they may have a discussion with the ID physician to decide on the final dose for the patient. So once the active TDM is started for a patient, we have regular schedule. We put a schedule for the TDM follow-up. So till the patient leaves the ICU. And for every 5 days, we wait for the MIC report. We discuss that with the clinical microbiologist if required, and we do a repeat measurement We also look at the clinical status. Clinical status is very important. Where is the focus of infection? So the concentration that we need to target for a patient depends on multiple factors: the clinical status of the patient, the focus of infection, etc. So that concentration is targeted, and we go for dose optimization. So as a summary, we observe huge inter-individual difference in pharmacokinetics of antifungal agents. TDM and MIC information gives objective goals for antimicrobial treatment and guides selection of appropriate dosing strategy for patient management. And use of PK models for dose optimization assists with selection of appropriate dose to achieve target concentrations. And for effective implementation of TDM, a team approach, as mentioned by Dr. Lee, by including a pharmacologist, microbiologist, and ID physician for dose optimization of critical ill patients is suggested. I thank my department, CMC Velo institution, and also the Asia Fungal Working Group and RAPS committee for giving the opportunity to present this topic to you. Thank you.
Thank you very much, Sumith. And now I will hand over the session back to Sharon.
Thanks, Van Hock. So my thanks to Sumith as well for a wealth of information, much food for thought. And our final speaker tonight is Professor Jan-Willem Alffenaar, who is now based in Sydney at the university, and he works with his team of pharmacists and clinical microbiologists and ID physicians, and he's well known to us for his deep interest in all things TDM, and he's going to talk to us about new antifungal agents and whether TDM is required. So thanks, Jan-Willem.
Thank you, Sharon, for the kind introduction. Let me share my screen. Yes, I think you can see the full screen slides, right? Excellent. Yeah, so thanks for the opportunity to talk about new antifungals and whether we need TDM. So I have a brief summary of my presentation. I'll first dive a little bit into the PK/PD, TDM, and then we will discuss some of the new drugs that we may be seeing soon in our clinic. So as already earlier mentioned, it's all about the relation between concentration of the drug and the ability of that drug to kill the pathogen. And we try to establish relationship which parameter predicts that kill best. And we have in vitro models, in vivo models. And fortunately, we're moving away from static concentration experiment to more dynamic concentrations, reflecting what's happening in the human body. And then, of course, when we move into our clinical trials, we will look at what's happening in first, of course, the healthy volunteers, but soon after we will study patients with actual disease and try to make sense of it, what's happening, and trying to establish an optimal dose. And then, of course, once we have established that, we can move into real life. And within real life, you will see a whole bunch of different types of patients that we have never seen in clinical trials. And then TDM may be very useful to guide those decisions. So just a recap of the principles of TDM. So we should have a therapeutic windows. Otherwise, we don't know what concentration we should be targeting for efficacy and toxicity. And of course, there needs to be unpredictable pharmacokinetic variability, because if we can predict exposure, we don't need to measure it. We can just predict it and be fine. And of course, because we have patients with multiple conditions, we can have interfering drug-drug interactions. We have fancy machines that we hook up to our patients to keep them alive. And of course, they may affect drug exposure as well. So at the end of the day, it's all about collecting the right sample to make informed decisions to improve patient care. And what we're really after is, should we be doing routine TDM for every patient, or should we just focus on selective cases? Because, of course, TDM is not cheap. Expensive equipment, and also staff time is limited, so we should use our available time and equipment wisely. So the question, should we perform TDM of new antifungals? And then I would like to go a little bit back in time, because if we would have had the talk in 2002, we would have said, oh, we don't need TDM of voriconazole. But nowadays, TDM of voriconazole is available in every guideline. So new antifungals are still drugs, so who knows? But what changed for voriconazole in those 20 odd years? And so, of course, we had our 2 New England studies demonstrating that voriconazole drug was a good choice for your patient. But then again, in the couple of years following these publications and market registration, there were clinical data demonstrating failure with low concentrations. Patients started complaining about side effects, visual hallucinations at high concentrations. We did a reanalysis of clinical trial data showing a kind of correlation with exposure. We better understood the impact of pharmacogenomics and fast and poor metabolizers of 2C19. We studied the effect of inflammation. And yeah, could they have known when they launched this drug? We don't know. Anyway, I think this is important to realize that voriconazole was first trialed in 1993. And if you look at the number of papers on PK/PD and drug concentrations, they really start to appear only for the last 10, 15 years. And before that, it was very scarce. And so upon the time of getting onto the market, there was very little study in this field. So I think with the new drugs that have been studied in the last decade or so, there should be much more information available. So there are always a few red flags. And one of the red flags I think of is a loading dose, because if your loading dose is not sufficient, it takes more time to steady state. And for some patients, that might be critical. If you have CYP metabolism for your drug, if you have polymorphism predisposing for rapid metabolism, there's risk for drug-drug interaction, so that's a red flag. If bioavailability depending on food, and we know that many of our patients in the cancer clinic are not really keen to take big meals. And also renally clear drugs if we have renal function loss. So there are all a bunch of reasons why pharmacokinetic variability might occur in real life. So these are a few of these new drugs, and there was already a question in the chat about isavuconazole, so I will discuss that as well in my talk. But there are a few other drug, risofungin, olorafim, and a whole bunch of other drugs that are popping up in trials and on the market. And I do have to make a disclaimer that I did not perform 6 systematic reviews to prepare for this talk, but I hope to give you a brief overview of what the opportunities are for these drugs. So first, the question is about isavuconazole. And if you look at the top right side, we do have some characteristics of that drug. It has a very good bioavailability. It is unaffected by food or pH. So the issues we had with itraconazole and posaconazole, no issues at all. There is metabolism through CYP, so that might be an issue. But general PK is linear. So opposed to voriconazole with non-linear PK, this might be a drug with a few less red flags than vori. So if we look at the trials that have been analyzed, and these were the phase 3 trials, and you see that there are a few patients outside the range. They could not really find a difference in treatment outcome and toxicity, and most of the patients attained the target. So if you compare this with the analysis of the voriconazole clinical trial data, that shows you a different picture. So although there are no real clues from these phase 3 studies, there are, of course, patients who are outside of that range. And I think what is important is that there is a fairly good relationship between the drug exposure and response. And you can see that at the bottom of the slide where they discuss the pharmacodynamics of isavuconazole in mold infections. So based on this data, you would not say that routine TDM is indicated for isavuconazole, but you have to think of your selected cases. Is there a red flag in my patient which justifies me taking a sample and having a closer look at the drug concentration? For risafungin, you see the big molecule at the top. It's like the micafungin, caspofungin, etc. It's a big molecule. The only difference with this one is that the metabolism is even less, so it has a very long half-life. So with a few of the other mechanocandins, there were loading doses involved, but still also with this drug, and they demonstrate that reaching adequate exposure early results in a rapid response. So still that concentration effects relation exists. In the studies that have been performed, there were a few covariates related to exposure, like set infection status, serum albumin, body surface area, but none of those were really clinically relevant. And then when they looked at MIC90s, for example, for albicans and glabrata, everyone attained the target throughout the treatment. So for this drug, you would not recommend routine TDM, like we did not for the echinocandins, but even in selected cases, it's likely not needed. If we can do a proper PK study to see what's happening with ECMO and dialysis, then we have solved those questions as well. Another drug, alorafim, is of course of great interest because it's completely a new class with excellent tissue distribution. It has a modest bioavailability, not as close to 100% as the other drugs, but there is a good a picture around Cmin over MIC ratios in relation to therapeutic response. And there is a loading dose, as I could find in this paper in Journal of Fungi, and also in clinicaltrials.gov, there is a description regarding a concentration measurement and adjustment. But overall, there's at this moment very little data available. So there are a few things that we need to address when more data appears, which is of course the issue with loading dose and the CYP metabolism. And likely we would like to see some targeted PK studies to understand better what the variability in patients might look like. And so for now, we cannot recommend TDM for this drug yet, apart from clinical trials, but perhaps it may be based on these red flags. Ibrexafungerp is also a new class. You can see the molecule here at the top, linear PK. There is a good bioavailability, but it is pH dependent. So like we've seen with posaconazole and itraconazole, that might result in some issues. And they've tested at this moment a couple of different dosages in clinical trials. And it seems that Cmax over MIC and AUC over MIC are correlated with therapeutic response in preclinical models. The issue with pH-dependent solubility is something that we need to address. I couldn't find a study yet where they compared it with omeprazole or another PPI or something alike, but that might be a risk if not addressed appropriately in the drug formulation. So although this drug is new and there's very little data, there are a few issues that we might have a closer look at when more data appears. And again, it's the loading dose. We might see a bit of PK variability, especially if it's pH dependent, because many of our patients are on proton pump inhibitors. So maybe TDM for this compound. Then we have opalconazole, another azole. And if you look at the molecule at the top, it looks familiar to some of the compounds we already know. It looks very much like itraconazole and posaconazole. However, it has a different mode of administration. It's an inhaled component and it accumulates in lung tissue. So for fungal infections occurring in the lung, it seems to be an excellent candidate, and especially when we're talking about prophylaxis, because if we're talking about invasive disease and there's growth outside the lung into the bloodstream, you can see on the table on the right that the plasma concentrations are not detectable, so that it seems that if you have an infection outside of your lung, and this might not be the mode of administration you would like to use. So based on this mode of administration and lack of penetration in plasma, TDM is not possible unless we go for very advanced methods. And there is, in this study, they have a look because they looked at the preclinical models where they used trachea sampling. But yeah, that may be a little bit far-fetched for our current TDM practice. Then we have Vulmanopix. This is a prodrug, and you can see the molecule at the top with the phosphate moiety. And upon absorption, that is removed, and then the active drug becomes available. There's a high bioavailability. It's not affected by food. Again, we have a loading dose, so that might be a little bit of a challenge if that does not result in the right exposure in some patients. They tested various maintenance doses, so clearly they haven't sorted it out completely yet. What is the preferred maintenance dose or loading dose? And also, they found interestingly that hematocrit values were found to affect the plasma concentrations. So that might be an interesting situation in some of our hematology patients or transplant patients soon after transplantation. So at this moment for this drug, there's very little data, but they did test a few different dosages. We do have a loading dose and a hematocrit effect. So it might be interesting to watch what's happening with this drug in the near future. So yeah, to summarize my overview of literature, so it seems that these newer drugs have less PK issues than the current antifungals, and particularly, I think this has been the result of the more intensive PK/PD studies for the past decade. We do want to see more clinical trials, of course, to understand what this means for our day-to-day patients. I think we can use a mix of TDM modalities where we have routine TDM on one side versus the selected cases on the other side. And of course, in those compassionate use situations, you don't require a randomized control trial to support your TDM, but just use your common sense to make anything meaningful work for your patients regarding TDM. So yeah, with that, I would like to almost conclude my presentation, but I would like to briefly ask attention for the chair and vice chair of our regional section for Asia Pacific for TDM. And this was recently founded in our TDM Society. And I hope that this, like the Asian Fungal Working Group, can make a difference in our region regarding TDM practice, research, and education. And with that, I would like to end my presentation. Thank you.
Thank you, Jan-Willem. It's very insightful, your talk, and I enjoyed it very much. So we now come to the Q&A section, and we do have some questions. So I will take the first 4 questions and then hand over to Van Hock, and then if we have any time left at the end, I have a couple of questions as well. So we have a question, and I think perhaps Debbie, you might like to take this one. Since Scedosporium species don't have a typical distribution of MIC or MECs, how would you predict the antifungal susceptibility of a single strain, particularly when the different species have different susceptibilities? Thanks, Debbie.
Thanks, Sharon. I think Lily actually covered a lot of this very nicely in her talk, so she may actually want to jump in at this stage. Lily? I mean, I think the bottom, and Sharon, I mean, as the head of the reference lab, you may also want to talk about this, but I think the bottom line is that the MICs that we get are a guide because of the variability in organisms, and they are just that, a guide. And you can say, well, it looks good or it looks much less good. and that may well help guide your therapy. But Lily, I'll hand over to you because you covered much of this in your talk.
Yeah, I actually expected these kind of questions. I myself has been asking the same questions. So a lot of time we don't even able to culture the fungus. So a lot of time we have to base on the epidemiological data that available to us, especially the local data. If you have the data of the Scedosporium, that what is the usual MIC range, that probably will be helpful, because we know that it's quite impossible to get the real-time MIC results that make available within the next 24 to 48 hours before we need to commence the antifungal treatment. So maybe Dr. Sharon would like to chip in as well.
Thanks, Lily. Interesting and difficult, isn't it? So if we have something like Scedosporium, let's pretend this is Lamentaspora as opposed to Scedosporium, and you know that most isolates are resistant to many of the antifungal agents. Until the CLSI or UCAS have come up with a category that says all Lamentaspora will be intrinsically resistant, you can't assume that they all are. And you will find the odd strain that might have a moderately low MIC to voriconazole or a lowish MIC to voriconazole. So it still is worthwhile testing the susceptibility of each individual strain, even though you know that you're likely to find it to be resistant. I hope that makes sense, because you can't, whilst you can predict for 95% of the strains, there will be an odd strain that will catch you out. I'm not sure if Van Hoek agrees with this, and he might have a different opinion, but that's what we see in Australia.
No, I'm like you. I would always try, because you do one off and on, get a decent seed that you could work on, I suppose. And TDM is where it's really helpful, because you can then try to get above that, as long as you're still within therapeutic range.
Yeah. I guess Candida glabrata is a good example to give, because it may have a fluconazole MIC of 4, in which case maybe you can get adequate concentrations. It may be 64, in which case you've got absolutely no chance. So I think that's quite a good example. The molds are a bit more difficult, but Candida glabrata may be susceptible. And so, for example, in the urinary tract, where we know the echinocandins have poor penetration, then you may choose a high dose of fluconazole as your treatment agent, given that you may well exceed the MIC of the organism, particularly with the urinary excretion of fluconazole.
Okay.
Yes.
So the next question that we have is, what are the barriers in testing biofilm MICs? Happy for anyone to take this. Debbie, you did mention biofilms in your talk.
Enormous, to summarize the answer in one word. It's extraordinarily difficult. It's really a research laboratory undertaking. It's not something a routine laboratory could ever undertake, because it actually involves adherence of the organism to a biofilm substance, be it plastic or whatever, or human tissue, and then the subsequent maturation of the biofilm, the addition of the antimicrobials, the electron microscopy, and so forth. It's extraordinarily difficult. So it's something we have to read and say, okay, we believe that's probably true. And the vast majority of papers do suggest that the azoles are extraordinarily ineffective in biofilms, whereas the echinocandins generally have very good activity in biofilms. Again, somewhat variable. Possibly microfungin has the best activity depending on the site of the biofilm. But certainly the azoles are poor in the biofilm setting. We know that. But testing it is very difficult. Sharon, it's not something you would do, is it?
No, Debbie, we would refer it to your lab, I think.
Oh, we don't do biofilms.
No biofilms?
No, definitely
Yes.
not. No.
Yes.
I don't know of any routine lab that would actually undertake it in Australia.
I mean, this is particularly pertinent with something like Candida auris. I know we're not talking about auris tonight, but auris forms thick biofilms, and you just wonder what its actual susceptibility is like, and that's why the breakpoints for something like auris are so hard to determine, even for amphotericin, where there are no ECVs or breakpoints. suggested breakpoints, but not definite.
Well,
Any
Candida
comments?
albicans actually forms a very good biofilm. It's probably the king of the biofilms, actually, as far as Candida species. Well, they're no longer Candida, as far as that group of organisms goes. So, yeah, I think the biofilms are really important, but we just have to extrapolate from the literature at the moment because it's not reached the position of being done in a routine laboratory. I don't know whether, Van Hock, whether you want to comment about whether it's done in Singapore or anywhere?
No, not to my knowledge.
Any other comments from the panel about biofilms and susceptibility? Okay, we might.
I think, Sharon, regarding the drug penetration, that's also an issue in addition to MIC determination, because some drugs might not penetrate that well into the biofilm.
Sure. Okay. All right. There was a question. I'll think of does the target site affect your drug concentration? So if you had a target site in blood with a target drug concentration, would that drug concentration be different in another site, such as CSF or, bile fluid or pleural fluid for that matter? Anyone? Jan-Willem?
I think we all agree on this question that yes, drug concentrations change throughout the body depending on the properties of the molecule. If you have a very big molecule, it will likely not penetrate into your CSF, for example, due to the barriers that they face. As Debbie already mentioned, some drugs might not end up in urine while others do. So you really have to be across the concentration of the drug and the site of infection and make a logic combination, just not look at the MIC only.
Okay, Dr. Mathew has his hand up.
Yeah, so the approach that we normally use here is we see where the focus of infection is, and depending on that, we suggest different targets for different patients, treating different patients. So it's not just the therapeutic range that we look at when we see the blood concentrations. So if the patient is having, for example, soft tissue infection of the leg, which is really bad, no circulation there, then we aim for a plasma concentration which is high in the therapeutic range. So as Jan-Willem rightly said, we have to have different targets for different site of infections. Yes.
Okay, thank you very much for that. My last question before I hand over to Van Hock from the attendees is, just trying to find it. Do you monitor posaconazole trough concentrations for PO-POSA prophylaxis? And do you try titrate the dose accordingly? Dr. Mathew? You're on mute.
I think Dr. Jan-Willem has answered this question. Any role to conduct isoconazole TDM? Only in special cases, I understand like that. It's a drug which have fairly predictable kinetics, pharmacokinetics. So when required, yes, you can do. Do you monitor posaconazole trough for per oral prophylaxis and titrate accordingly? Yes, of course, we do that. Especially for hematology patients, to prevent the invasive fungal infections, we monitor most of the patients with, especially the ICU patients, we monitor the posaconazole trough. And we do that at least once in a month. That's a recommendation that we give generally to them. Yes.
Yeah,
Yes.
if I can add to that, Sharon, is that it's particularly important for the liquid formulation. It's less important for the tablet formulation because the company made sure that those are not as susceptible to pH and all those factors which influence the absorption from the liquid formulation. So if you have the opportunity to use tablets, it prevents a lot of headaches. Yeah.
Although certainly a number of patients can still be subtherapeutic. I mean, we
Sure.
do monitor all of our patients on prophylactic posaconazole and itraconazole, as Zach showed in his presentation. And in particular, amongst the heart transplant recipients, we've seen a significant percentage, we're just in the process of counting it up now, who are actually very subtherapeutic on posaconazole for no apparent reason. There's no obvious interacting drug. They're using the tablet formulation, but they are subtherapeutic. And often we end up with having to double the dose for adequate prophylaxis. So yes, we do measure it, as Sumith and Jan-Willem do, but we also dose adjust appropriately.
Okay, thank you, Debbie. I'll hand over to Van Hoek.
Yes, thanks, Sharon. Okay, the next question from the audience, I think this is for Dr. Sumith. Does optimized drug regimen in best dose also optimize the timing of the dose?
So when we click the button optimize the dose regimen, it means you have to decide at what time you need a particular level concentration. So that we have to decide, is not the best dose which decides that. So yes, so once we decide the time, then the optimization, the software will be able to, the model will be able to tell the dose required to reach that target at that time. Yes, yeah. I hope that's clear.
Thank you. Yes, it is clear to me. Okay, this one, I think all the speakers who run labs can answer this. Which method do you use for TDM? Maybe Jan-Willem can start.
Yes, so there are various methods available, and depending on where you are, you might use a different one. So there are immunoassays for voriconazole available, but for the other azoles, there are no commercial assays available. So you have to develop either a LCMS, LCMS-MS, or HPLC UV method. And depending on your setting, you might have money for an LCMS-MS, or you can run it on an HPLC UV. But mostly in the therapeutic range, so in the milligram per liter range, most of these machines are able to measure it. LCMS-MS is a little bit faster, can measure a little bit lower, but if it's subtherapeutic, it doesn't matter how subtherapeutic it is, it's still too low. So for clinical decision making, it doesn't have to be extremely sensitive.
Thank you. Debbie, you want to add anything to that?
No, I think that was a very thorough explanation. We use mass spectroscopy here, but obviously HPLC is a lot cheaper in some settings. And as Jan-Willem said, the availability of immunoassays for more than just voriconazole would be fantastic. But I'm not sure that's going to happen in the foreseeable future.
Good. Sumith, do you want to say anything from a affluent country?
We use here the HPLCs, and most of these antifungals have UV absorption spectrum, so HPLC work. Of course, the other options also are there. Immunoassays and MS, yes, all these work.
Thank you. Okay, this is an interesting question which wasn't touched on. Is there a role for TDM for echinocandins and liposomal M4? Debbie, I think you've done some work on TDM for echinocandins.
I think there is a role, although you can probably predict the patients who are actually going to be likely to require higher doses of echinocandins. So it's usually that the dosing will be subtherapeutic rather than toxic. I don't think a toxic concentration's actually been established for most of the echinocandins, but certainly in certain clinical settings, such as the critically ill patient or the morbidly obese patient, we probably significantly underdose the echinocandins. So I think in that setting, there certainly would be a role for therapeutic drug monitoring. Unfortunately, it's just not generally available at the moment, but it's highly likely that we are underdosing patients, and maybe some echinocandins are more underdosed than others. Extracorporeal membrane oxygenation is another setting whereby we're probably underdosing the echinocandins. Perhaps dialysis, we don't know. But Jan-Willem might like to comment on this as well, because it's an area of interest of his. But certainly, I think there is a role for TDM in certain clinical settings, if only we had access.
Yeah, thank you,
Yeah.
Debbie. So when these echinocandins entered the market, we did 3 trials in our ICU to look at the exposure of the 3 echinocandins. Depending on the available targets at that time, there were patients with lower exposure, whether they failed treatment. They didn't, but that also depends on the susceptibility of the pathogen. But indeed, I agree with Debbie that higher body weight is a significant predictor of too low exposure, ECMO as well. With dialysis, the drug is not removed because it's extremely high protein bound. So for dialysis, I'm not too worried. Some drugs might be a little bit like caspofungin, a little bit susceptible to drug interactions, a little bit more than the micafungin and nedlafungin. But overall, I think it's the safest class and the easiest to dose. And if you have doubt about the exposure, just increase the dose. It will not cause any toxicity. Perhaps your financial department may be a little bit nervous at certain stages.
Financial toxicity.
Yeah, financial toxicity. But yeah, otherwise, if it's about the survival of the patients, I would easily increase dosage of echinocandins.
I mean, I think there's a fair amount of data now to suggest that dosing on a milligram per kilogram basis would be more appropriate, but it's just something that's not been widely adopted, unfortunately.
Okay, thank you. Liposomal M4. Anybody wants to comment on that? Jan-Willem, perhaps?
Yes, I would like to comment. Tony Lai, AMS pharmacist at the Kids Hospital in Sydney, just started his PhD on this drug, liposomal amphotericin. His whole PhD is about TDM. So hopefully in about 3.5 years, he can provide you all the answers. At this moment, I think many people make attempts to measure it and struggle with the unbound and bound and in-out liposomes. So it's a challenge, but hopefully Tony Lai can provide us the answers in a couple of years.
Well, even conventional amphotericin B is a challenge too, isn't it? And do the serum concentrations represent what's going on in the tissue? That's always been the other issue, hasn't it? That is it actually worthwhile measuring, because we don't know what serum concentrations mean compared with tissue concentrations. So it's a difficult drug, amphotericin.
Yes, thank you. So there's a very good question here from Caitlin, I think. We probably don't have time to go through all the questions, but there's a very interesting one, something that we deal with quite regularly. It's about the use of fluconazole TDM for crypt-Gatii. As we know, the target is an MIC over AUC of 400, but troughs are probably very high if we want to hit that. So is that what we want to do for consolidation, or is that only induction? I have no experience with fluconazole TDM, so maybe Debbie, Jan-Willem.
Debbie, you would like to go
Jan-Willem?
first? I already talked to Caitlin before the meeting, so happy to hear your ideas.
Yeah, it is hard to hit that target of 400 depending on the MIC of the organism. And in fact, if the MIC is high, we would actually tend to often use voriconazole. So it's never actually been marketed or approved for Cryptococcus because the studies haven't been done, but the MICs are generally much lower and the penetration into the CNS is usually excellent, as you saw from that slide I showed, that the concentration in brain and CSF is usually good. So we would often, if the MIC is high, change to voriconazole and see how we go with that. But it is, you're probably looking at, 400, AUC of 400 is going to be a serum concentration that's quite high and quite difficult to achieve until you get up to doses around 12 to 1600 milligrams sometimes, which we've used safely. We've used 1600 milligrams a day for 3 years in a patient once before voriconazole became widely available, and he did very well. But you are looking at fairly heroic doses often to achieve that AUC. You're correct. Sharon, do you want to comment?
Yes, Sharon.
Yes, thanks, Manhok, and thanks, Debbie. I was going to ask you, Debbie, about high doses in Gatii because, you know, as opposed to neoformans, we do push up our dose of fluconazole. I certainly use a minimum of 800 for consolidation and higher sometimes. And so you are recommending a dose of at least 1600 to get up to the
It depends on the MIC of the organism. If
Right.
the MIC is high, then I would push the dose up, absolutely. If the
Yes.
MIC is sort of standard MIC for GATI, not in the high range, then probably 800 is sufficient. But I mean, the original data was 400, then 200 milligrams a day of fluconazole, which is homeopathic, I think. It's really subtherapeutic, and that's why I think there were treatment failures early on, because the dosing was inappropriately low.
I agree with you, and we're getting a little bit of the topic in terms of crypto, but I think in the new crypto guidelines that are about to be published, written by Christina Chang and John Perfect and colleagues, they are going to recommend higher doses for the consolidation phase, which is a good thing. Thanks for your insights.
We
I'll
only
keep
have
quiet now.
a minute left, actually, or probably no more time. So I'll hand you back to Sharon so that we can close what has been a very interesting and educational meeting. Sharon, please.
Thanks, Van Hoek. So firstly, I'd like to thank our speakers, Debbie. I should lower my hand. Jan-Willem, Sumith, Lily, and Zach. It's been very instructive, and I certainly have enjoyed it. So as I indicated in the beginning, we will be doing 4 of these webinars a year, and the second one for this year will probably be held sometime in May, and I will liaise with Van Hoek about the topics and the speakers and what we should be doing. But we try to vary these a bit. So we had one session on crypto, we had one session on Canada last year. Today's is on TDM, and we'll talk about something else the next time. And I thank you all for coming, and thank you for your time. Some of you need to go for dinner, some of you need to go to bed. So I'll say good night and see you next time.
Thank you.
Goodbye.
Bye-bye.
Goodbye.
Thanks, everyone.
Thank you.
Thank you.